All right, hello and welcome. Today we are diving deep into something most of us have dealt with, a nasty sore throat. But we're going way beyond just gargling with salt water. We're going to trace the entire journey of pharyngitis and tonsillitis, from the moment a patient walks into the clinic all the way to the lab and the final prescription. It's a fascinating look at how medicine and microbiology team up.
So here's our game plan. We'll kick things off with the disease itself, then follow a sample into the lab. We'll ID the bad guys, figure out how to take them down, and talk about treatment. Then we'll get into the scary stuff, complications, before we wrap up with a little quiz to test your knowledge. Let's get started.
Okay, so everything starts right here, in the doctor's office. The patient comes in complaining of a sore throat. And this is one of the single most common reasons people see a doctor in the first place.
So, what are we actually talking about?
Well, pharyngitis is just the medical term for an inflammation of the pharynx. That's the area at the back of your throat. If it's mainly the tonsils that are inflamed, we call it tonsillitis. Simple enough, right? But the real challenge, the whole point, is figuring out what's causing the inflammation. That's what changes everything. Now, a good clinician is like a detective, and right away they're looking for clues. The first big question is viral or bacterial. If you've got a cough, a runny nose, maybe some pink eye, it's almost certainly a virus. And that means antibiotics are totally useless. But if it's a sudden, nasty sore throat with a fever, and here's the key, a total absence of a cough, that's a huge red flag for a bacterial infection, like group A strep. This first call is absolutely crucial.
So let's say the doctor suspects a bacterial cause. They take a throat swab. Now we're going to follow that little swab on its journey into the microlab to see how we unmask the real culprit. In the lab, everything follows a very precise process. That swab is basically used to paint the sample onto these special petri dishes filled with agar. Then, those plates go into an incubator that's set to mimic the warm, cozy conditions of the human throat. It's the perfect environment to encourage any lurking bacteria to grow and form visible colonies. Techs will check these plates every day, on the lookout for anything suspicious.
And this is really cool. It's not a one-size-fits-all approach. The lab uses a whole menu of different media to catch different bugs. The blood agar plate, for example, is perfect for spotting group A strep because of the way it breaks down the red blood cells. But for me, the most important one for really sick patients is the anaerobic plate. It's designed to grow bacteria that hate oxygen, like Fusobacterium, a name you'll want to remember because it's linked to some really serious complications.
So after a day or two in the incubator, what are we actually looking for on these plates? Who are the usual suspects when it comes to bacterial pharyngitis?
Well, Streptococcus pyogenes, that's group A strep, is definitely the headliner. It's the big one. But it's not a solo act. You can have a whole host of other bacteria involved. Those anaerobes, like Fusobacterium, are super important in severe cases. And honestly, a lot of the time, especially with abscesses, you find a whole polymicrobial party going on, with bugs like S. aureus and even fungi like Candida crashing it.
Okay, so once we've identified our pathogen, we need to figure out its kryptonite. We do this by finding something called the minimum inhibitory concentration, or MIC. Just think of it like a tiny cage match. The lab pits the bacteria against different doses of an antibiotic to find the absolute minimum amount needed to stop it from growing. That one number, the MIC, is the key to effective treatment.
So how does that number, the MIC, turn into a prescription? Well, that number gets compared to a set of official breakpoints, and the bacteria is labeled either susceptible, intermediate, or resistant, SIR. Susceptible is a green light. The standard dose of the drug should work. Resistant is a red light. It's probably going to fail, so you need a different drug. That SIR report is the critical link between the lab and the patient's bedside. And now we bring it all together. We've got our bad guy, we know its weakness, so now we can finally select the right weapon and the right dose for the fight. For really serious infections, the ones that land you in the hospital, treatment gets aggressive. And there's a clear logic here. If it's a really bad strep infection, you hit it hard with IV penicillin. But if you suspect an abscess is forming, you have to add metronidazole to cover those anaerobic bacteria. And if you think S. aureus might be in the mix, you switch the main drug to something like flucloxacillin, but you keep the metronidazole. You're covering all your bases. And just for a second, a little nerdy humor for you. Don't worry, the punchline will make a lot more sense in just a minute, I promise. Of course, treating kids is a completely different world. You can't just guess or give them a fraction of an adult dose. No way. Every dose has to be meticulously calculated based on their exact weight. It's all about milligrams per kilogram. And for some high-risk kids, say a child without a spleen, they might even need antibiotics long-term just to prevent a catastrophic infection. So, let's zoom out from the individual patient and look at the bigger picture for a second. How do we prevent this stuff from spreading? And what happens when treatment fails or comes too late? This right here, this is exactly why we take bacterial sore throats so seriously. An untreated infection, especially from that fusobacterium we talked about, can do something terrifying. It can invade the jugular vein in your neck, forming infected blood clots. Those clots can then break off and travel to your lungs, your joints, your brain, triggering septic shock. This terrifying chain of events is called Lemierre syndrome, and it's how a simple sore throat can kill you. Okay, it's time to put all this information into practice. Let's work through a quick clinical challenge that doctors and pharmacists face constantly. So here's the scenario. You've got a patient who needs an antibiotic, but they tell you, "Oh, I think I had a mild rash to penicillin when I was a kid." This is a classic dilemma. Can you safely give them a closely related drug, like a cephalosporin? What do you think? And the answer is, it depends, but it depends on the chemistry. See, I told you the joke would pay off. The risk of a cross-reaction isn't about the whole drug class. It's about a specific part of the molecule called the R1 side chain. If you pick a cephalosporin with a side chain that looks different from the penicillin the patient reacted to, the risk of a reaction is incredibly low, less than 1%. This is a perfect example of how a deep, nuanced understanding allows for smarter, safer prescribing. And that leaves us here with one of the biggest challenges in modern medicine. We know that a sore throat can spiral into a life-threatening disease that needs powerful drugs. But we also know we're in a crisis of antibiotic resistance, which is driven by overusing those exact same drugs. So how do we walk that tightrope? How do we balance protecting the one patient in front of us with protecting these precious medicines for all of us in the future? That's the question. Thanks for joining me today.